So welcome to day 4 of Clear Week 2023, when we're sharing the learning of our Clear projects. This is our first session today, redesigning same-day primary care in Somerset. This is focusing on the recent Clear work with North Sedgemoor PCN to support the network to increase access and equity for patients. Please note this webinar will be recorded so we can share it with others who are not able to join at this time. And please also follow us on Twitter and share your thoughts on the session using hashtag ClearWeek, and our handle is @Clear4Care, and you'll see that in the chat. So our speakers today are Carl Hepburn, who's PCN Clinical Director and Lead Clinical Pharmacist with North Sedgemoor PCN, and Dr. Eve Corner, who is our Clear Same Day Primary Care Project Clinical Lead. Over to you, Eve.
Morning, everyone. Welcome to this session. Kyle and I are going to be being a double act today, so I'm going to give you a bit of a kind of navigate you to what we'll cover within the webinar, and then I'll hand over to Kyle to give you a bit of an introduction to the context and set the scene. Then I'll present the outputs from the Clear work, and then I'll hand back over to Kyle to offer some reflections on the process so far. So feel free to put questions in the chat or ask questions as we go along. I'm happy to answer them, but we can also have a Q&A session at the end as well. So I think Suman is navigating the slides, so if I could just ask you to move on to the next slide, please, that'd be great. So what we plan to look at today is the known challenges and the scope of the project, which Carl will talk through. We'll then go on to the Clear methodology to give people that are less familiar with how Clear works a bit of an idea of the process itself. Then talk through some of the key findings from both the qualitative and the quantitative data, the new model of care, and an example of the new model of workforce that's been recommended. We'll then have a bit of a look at the overall workforce model and the projected impacts of this work, and a bit of a summary. This project has been a huge project, so we haven't been able to cover all of the elements of it in terms of the workforce modelling, but hopefully it will give you a kind of snapshot into the recommendations and what we've come out with. So if we can move on to the next slide, and I'll hand over to Kyle to set the scene for you.
That's great. Thanks, Eve. Yeah, so thanks everyone for coming along and hearing our story of what we've been doing in our area in North Sedgemoor at the very top of Somerset. And we are working in primary care as a primary care network. And as the slide says, we've had some clear challenges that we're all facing into in primary care. We're very aware that there's an increasing demand on our services that is causing more and more problems with regards to access. We have a decreasing workforce globally, that we're seeing fewer and fewer people being able to stay or want to stay within the networks. And we've also had a significant challenge in our area where we're noticing that across our PCN, we've got 5 practices, and between them, there's a lovely divide down the middle called the M5. And depending on which side you live, you may have better access to appointments than the other side. And that's causing significant challenges and problems for us. And we're not unique in this, but our practices have been thrust together because of the primary care network contract days, and that forces independent businesses to now work together collaboratively and to make some things happen. And those are big challenges, because that historically in our area and in others, I'm sure, has not always been easy to navigate and to do that. So if we can move on to the next slide. I think, though, we need to be clear. We're not really sure what the increasing demand is, and we've had significant problems understanding what that means. Everyone says the demand is increasing, but we don't have that. And that increasing demand is causing problems because what we're recognizing as clinicians is that we're not operating safely, and we need to be honest about that. But that also impacts patients. They're not getting safe care. And what we want to be able to look at is, can we be clear about what is a safe day look like for us as clinicians, but also as patients coming into our services and who need that care? What does the decreasing workforce look like? Is that because we have no GPs? Is that because we haven't got other roles? And we are in a situation now where general practitioners are really disenfranchised with what's going on in primary care. They're finding it harder and harder to stay in this level of work because the demand is increasing, and they're finding themselves left out on that limb. And we are having this cohort of doctors deciding to leave or do something very different and not actually stay in and deliver clinical care and primary care, but do other things. And that's a big challenge. The other things that we needed to be clear on is it same day care that's causing our problem, or is it routine care that's causing the problem? Which one is being affected because of this increasing demand? And we have a feeling, but we didn't really know. And what is the major problem, and which is same day care? Is it when your diabetes is basically out of control and you haven't been seen for a long time? Does that become the same day problem? Or is it actually a same day problem that just isn't managed because someone else has taken up the appointment and we've got our full caseload done? And then the last thing is we need to be really honest about how are we actually working together within the primary care network. We've been able to establish some wonderful working patterns across COVID, and that's because a lot of the barriers were broken down and you just had to get stuff done. But also lots of other things were stopped, and therefore that allowed us to be able to create and collaborate in a safe way because it was necessary and other things didn't be a priority. So that was really, really important. So we were able to think about those things to try and get us on this project. So can we move on to the next slide, please? So we wanted a clear plan. You can tell I'm in for the puns. How busy are we really? What does that really look like? And what is our actual demand? Can we actually work that out from our data that we have? And no one's able really to do that in primary care. It's all very wishy-washy. What workforce have we actually got? We've been able to utilize the ARRs roles in the PCN DES, but again, we haven't maximized those, and there's new roles being added all the time. So who do we have? What does our workforce look like really? Is that GPs? Is that nurses? Is that these ARRs roles? But what do we need and who do we need? And we didn't have the answers for that. And the big thing what we wanted to really ask ourselves is, at the moment, on a same day level, we're not operating safely. So how can we actually do something about that to allow us to operate safely and manage same day care in a way that means that patients will get their same day care given to them on the same day, rather than just being, please call back tomorrow, or please go to MIU, or please go to A&E, when actually those places aren't the most appropriate place. And the last thing we wanted to look at from a plan that we wanted to build off this project was, how can we actually build something together that's sustainable and that will last? And that's what we wanted to try and achieve from the outcomes of this project, was to have those questions answered in a way that allows us to facilitate building something new and lasting for patients that keeps them safe, but also for us as clinicians that keeps us safe as well. And that's a bit of a background of how we started it. Is this me as well, Eve, or is this you now? Can't remember.
Yeah, I can take over from here if that's
great.
Thank you for setting the scene nicely, Kyle. So once we'd gone through the EOI process, we then had a scoping meeting with the team at North Sedgemoor, with some of the key stakeholders to really understand what it was that they wanted us to look at. And so the focus for this project was really patients that required same-day urgent care, patients that were at high risk of requiring same-day urgent care, and looking at how we could change the clinical model, change the workforce model within the context of the initiatives, the broader initiatives that were going on across the ICS and across the PCN, and try and integrate those ARRs roles along with the traditional workforce to get the maximum capacity to deal with the increasing demand. Go on to the next slide, please. So how do we approach this within CLEAR? So for those of you that are less familiar with the CLEAR methodology, CLEAR stands for Clinically Led Workforce and Activity Redesign. It's a programme that was designed by clinicians for clinicians, recognising that clinicians often have the answers and the solutions, but don't necessarily have the headspace or the data in order to create the narrative required for change and implement that change effectively. So the CLEAR methodology was born off recognising this as a potential problem, and the way that we work is that we have clinicians that are dual trained in their clinical background, but also in the CLEAR methodology, who can work in a co-design approach with clinicians within that service to come up with new models of care, redesign services, and aid in the recovery and restoration of the NHS. So in terms of the way that we approach this, there are 4 different stages to the CLEAR methodology, and the first is the clinical engagement stage. This is really about understanding the baseline models of care, so getting a really good idea of what happens now, what is the business as usual situation. But it's also really important in forming those relationships with the teams, understanding what their issues are from a qualitative perspective, and securing that buy-in really, and that ability to work collaboratively on these projects, as well as the operational insights that we need in order to inform change. So whilst our clinical team are busy doing the engagement, we have a data team that extract the data, and in this case it was mostly EMIS data for the past 5 years. That data is cleaned, validated and converted into data dashboards. And what we do then is take the information from the clinical engagement, form hypotheses and start to investigate the clinical data, looking at cohorts, looking at how patients flow through a service, all sorts of different things that we can visualise within the data itself. What we did for North Sedgemoor was then bring that information together, bring the clinical engagement findings with the data, the findings from the data visualisation, to run an innovation workshop where we worked with staff members from across the PCN to look at how things could be done differently. Key to this was really identifying the areas of overlap between the practices in order to identify where collaboration could be most beneficial. Once the innovation is then developed, we do a workforce modelling approach where we look at what workforce would you need in order to deliver that model of care, and what alternative roles could be used within that workforce. And finally, we do an impact analysis, and we look at impact in terms of the impact on the patient, the impact on the workforce, and the impact on the finances. This comes together into a final recommendations report, and this is disseminated and reported back widely. And we are also talking with Carl about further support around implementation of this new model of care as well. So if we move on to the next slide, I'm going to jump straight into the findings. So the next three slides really summarise the key findings that have brought together the qualitative and the quantitative data. So what we were hearing from the workforce was that demand was increasing and workforce availability was reducing. And this was very much corroborated by the data. The demand for same-day appointments, so appointments classified as urgent on the system, had increased by 18% over the 5-year time period. With the current model of care, in terms of the patients that were, the reasons that patients were accessing those same-day appointments, you would require across the PCN nearly 23 whole-time equivalent GPs, based on the proportion of those patients that GPs were seeing, in order to manage that demand. When we looked at it on a patient level, the average patient had one more appointment per year in 2022 compared to 2017. So we could see this increase in demand, not just at an aggregate level, but also at a patient level. Qualitatively, we were told that there was difficulty recruiting and retaining staff. There were cases of people leaving as well for multiple different reasons, career progression, retirement, but also some burnout and sickness as well. This had led to a staggering increase in the amount of locum activity, which had increased by 185% over that 5-year time period, which has a huge financial impact on the practices, as a locum costs on average about 2.2 times the salary of a salaried GP. What we also noted from the data, we looked at the read codes associated with appointments classified as urgent and appointments classified as routine. And what we saw was actually that read codes were the same. It didn't matter whether the appointment was an urgent one or a routine one. The conditions that the patient were presenting with for both of those appointments were consistent. And this was in part due to the lack of ability to deliver routine appointments in some cases, just because of the sheer demand for same day. So that was the kind of one of the big factors in that, but also patients not wanting to wait for a routine appointment and therefore asking for a same day appointment, whether it was clinically necessary or not. And the final point on this slide is around demand shift. What we noticed and what we were told was that demand was shifting around the PCN. There were changes to the geographical boundaries of the practices. There was estates being built, so housing estates being built in the area, with bringing a population in, and there had been some list closures or temporary list closures, which had led to patients changing practices and some kind of voting with their feet as well and moving practices. And this creates an unstable situation in terms of the practices that were currently coping with capacity and demand may not be coping with the capacity and demand in a year's time, with this demand moving and shifting across the PCN. We move on to the next slide, please. The next key finding from the data was around the availability of appointments was compromising access to care, and this was particularly bad for the deprived patients. So there was significant inequity of access to appointments across the PCN, with some patients having 50% fewer appointments than others. Those that had fewer appointments were much more likely to attend ED as well. So if the patient couldn't get the appointment, they'd go over to the ED department or the MIU in order to access that care. And this was affecting the more deprived patients more than the less deprived patients. The most deprived patients had 65% fewer appointments than the least deprived patients. So there was a health inequality issue that we could see within the data. All of the practices wanted to deliver continuity of care, but this was increasingly difficult in all practices really, but affecting some more than others. And in those where the demand far outweighed the supply in terms of the demand from patients and the supply of the workforce, their focus had to shift from continuity of care to access first. And again, I want to make the point that this isn't a static situation. There is a risk that all of them would move into this zone of inadequate access. Move on to the next slide, please. And the final point from the key findings was around the challenges within the PCN that made collaborative engagement difficult, but also we felt that it was really essential to think at this place-based level. Collaborative working across the PCN was impaired by a few different things. One was around concerns or a perceived lack of transparency about resource allocation and finances, and how PCN money was being distributed, and financial stability of practices. There were some concerns regarding the loss of autonomy, that working together would mean working in exactly the same way in a standardised fashion without having much control about how you want to practice. And finally, there were concerns around the perceived differences in caseload. So there was a perception that the patients were very different, the populations were very different. But actually what we saw from the data was that there wasn't that much difference in the populations. The only major difference really was the deprivation. But in terms of the presenting problems, they were very consistent across the PCN, which we felt created a good opportunity for collaboration. We also felt that this was essential due to the shifting demand of across the network, and also the workforce crisis that is a national crisis, but obviously also affecting the Southwest as well. So in terms of what we wanted to achieve with the new model of care, the key elements that we've recommended for this new model of care are a central point of access phone number for same-day appointments with some automated functionality to direct patients to the right place. What we were hoping this would do is increase equity in terms of access. An enhanced triage process with a PCN-wide agreed standard operating procedure. We could see that patients were accessing same-day care that could or should really be going into a routine appointment. Enhancing that triage will hopefully help to ensure that the patients are being seen in the right place by the right person. The next element was around the same-day care hub. Sorry, can you just move on to the next slide briefly for me? Okay, yes, sorry, if you flip back. Sorry, the slides have been adjusted slightly. So the next element was around the integration of a same-day care hub. So this is something that we're moving forward with already. Carl and his team are moving forward with. But what we've recommended was that a same-day care hub is developed within the primary care network, initially as a respiratory hub based on the funding from NHSE for the development of respiratory hubs, and then expanded to include all same-day appointments across the PCN. The recommendation in terms of how this is managed is to utilise the ARRs roles, with GPs working more in a consulting fashion, as they may do within an ED department, for example. The ARRs roles were recommended to be included in this same-day care hub for the management of those acute kind of medical conditions are first contact practitioners, advanced clinical practitioners, and physicians associates. So this would be for patients that required same-day care that's very much a kind of medical issue. But we've also recommended the integration of some other hubs within this pathway. The next one is a skin lesion clinic. This is utilising and integrating the use of AI technology that has been shown to be able to detect the presence of a problematic skin lesion, and off the back of using this technology, it can give you the appropriate clinical recommendation in terms of treatment and care. This skin lesion technology, AI technology, is being utilised in multiple different areas across the UK. It's being used widely in Birmingham and widely across Kent. And the way that they're managing that is to have, in some cases, a phlebotomist, but we've recommended here a nursing associate-led clinic who's able to take the image of that skin lesion, which is then uploaded to the software, and that software can make this clinical decision, which is superior to a clinical consultation in terms of the next intervention that's required. If no intervention is required, the nursing associate can then provide some information to the patient, and they can that would be the end of their journey in terms of this particular complaint. But some patients would be referred on into the dermatology department, and some may then go on to see the GP. If we go on to the next slide, please. The next element of this pathway is the mental health hub. So there was what we saw within the data was that a lot of patients were presenting with issues around anxiety, depression, mood-related issues as well. And that was using up a lot of the appointments, the same-day appointments for the GPs. What we had seen within some of the practice is that they'd had a really, really good impact with the integration of mental health practitioners to manage and see these patients, as well as health and wellbeing coaches. So our recommendation is that through the single point of access, the patient calls in with their same-day care requirement. They then go through this enhanced triage process. If it's an acute medical problem, they will go to the same-day care hub. If it's an acute mental health problem, then they will go to the mental health hub, where they'll get a 30-minute appointment with this trained mental health practitioner or health and wellbeing coach. This extends the amount of time that the patient has with the clinician, and also they have that very specific training on mental health management. If they go through that single point of access and through that triage process, and they have a musculoskeletal condition that requires same-day care, they would be sent to the musculoskeletal hub. And this is integration of MSK first contact practitioners that have shown to have a really, really significant impact on demand and on outcomes for patients in primary care. And they make musculoskeletal conditions make up a good kind of 20% of the same-day care demand. The final element of the pathway was the integration of a women's health hub to provide holistic and integrated care. Now, this doesn't necessarily link to same-day demand, but it is considered best practice, and there's lots of case reports of really, really good patient outcomes with this women's health hub approach, and it would reduce the traffic through the GP practice itself. And finally, in terms of the key elements of the model of care, we've recommended optimisation of existing services, and these include the acute eye care service, the pharmacy service, promoting this optician to ophthalmology referral to reduce some administrative burden, and some optimisation of warfarin, so looking at who could be switched off warfarin in order to reduce the burden of warfarin monitoring in clinics. So in terms of a summary of that new model of care, what we're trying to achieve with this is improving equity. The single point of access, we hope, will even out the equity of access across the primary care network. This improvement in the triage process will help to ensure that the patients are streamed into the right places, So they've got the right appointments, so urgent or routine, the right workforce, and the right place of care. We've been able to increase the appointment times for a number of different areas. So for the women's health patients, for the mental health patients, and for the musculoskeletal patients, their appointment time will be longer. And it will have the management of these patients within this central same-day care hub that have medical issues. What we've also been able to do is optimise the use of ARRs roles, with GPs working in a consulting fashion for same-day care to increase capacity and meet the unmet demand. And finally, the development of these condition-specific hubs releases GP consultation times, improves access, and allows GPs to really focus on the needs, the patients that really need GP input. Move on to the next slide, please. So this slide just gives you a bit of a summary of one of our workforce models, and I think it's important to make it clear that this is an element of that same-day care workforce modelling. It doesn't include the musculoskeletal or the mental health. We've done that separately, and happy to provide information on that, but just don't have really the scope to cover that within this session. So it's a bit of a busy slide. I'll just navigate you to it slightly. You can see on the table that you've got the top row, which describes the current model of care in terms of workforce, if it was scaled to meet the demand. So if you scale the model, if you scale to meet the demand, you would and use the same proportion of staff members to do that, you would require just over 7 whole-time GP equivalents for this same-day care hub, 1.6 advanced practitioners or first contact practitioners, and a bit of practice nurse, HCA, and administrative time as well. With this new model of care that has that enhanced triage process, and the patient's going to and increase utilisation of the ARRs roles, we were able to reduce the whole-time equivalents to 2.85 GPs, but that also factors in consultation time for more complex patients and quality assurance time for the patients that are being seen by the physician's associates. What we've also done is increase the number of ACPs and PAs, so that goes up to 4 whole-time equivalent ACPs and 4 whole-time equivalent PAs, and an increase in the HCA activity as well for the clinical observations when they first arrive at that same-day care hub. In terms of the impact of that model, what we're obviously creating is a more diverse workforce, but there's also a financial impact. The current model of care, if it was scaled to meet the demand, would cost around 1.1 million if it was staffed by a salaried GP. This rises to 2.2 million if it was staffed by a locum GP. With this new model of care that we're recommending, the costs would come in at around 1 million. So this is a cost saving of anywhere between 150,000 and 1.2 million per annum. If we can move on to the next slide, please. So as I've said, we've done this workforce modelling for all elements of the hub, and this is a bit of a busy slide, and I don't want you to go into lots of detail reading it, but what I'd like you to just note is the number of rows in the smaller table versus the number of rows in the bigger table. In the smaller table, we've got the combined elements of the workforce in terms of whole-time equivalent and job roles. And in the bigger table, we've also presented the same data for the new model of care. And what you can see with that new model of care is you have far more diversity in terms of the roles that are being used to deliver that care, and a reduction in the requirement for GP whole-time equivalents. Overall, your workforce numbers do actually go up, but there's increased diversification of that workforce and a reduction in consultation activity for the general practitioners. If we move on to the next slide, please. So what we then went on to do is to model the impact of this new model of care, and we've looked at that in terms of patients, workforce, finances. In terms of our patients, what this is enabling us to do is increase appointment lengths, and also the new approaches we've taken have reported satisfaction within the literature. So the patients with a musculoskeletal condition would get a 20-minute appointment. Those with a mental health condition would get a 30-minute appointment, and up to 60 minutes with for the women's health appointments as well, depending on what they're coming in with. In terms of recruitment and retention, there's no kind of quick fix really in primary care. Workforce is an issue, but what this has enabled us to do is think differently about the roles and how they could be used, optimise the ARRs, DES, create professional development opportunities. So, for example, the integration of a nursing associate role. It may be that there's a healthcare assistant working within the PCN who would like to develop and like to be given that opportunity to go through some further training. So it creates those professional development opportunities that could also tie into the apprenticeship levy, which North Sedgemoor has access to. And finally, it increases your recruitment pool. We know that there's real difficulty recruiting GPs, but if we have a variety of different roles to recruit from, then we have a much bigger pool of people to bring into the service. From a financial perspective, the cost of this new model of care, new model of workforce, is anywhere between around 230,000 and 2.2 million less per annum than the current model of care. And this is really depending on the ratio of locums to salaried GPs. We haven't factored in a partner GP salary into this modelling, but that would probably be somewhere in the region of the locum salary. In terms of staff workload, what we're also doing is releasing 43,000 GP consultations per annum, which equates to around 8.2 whole-time equivalent GPs. So if we move on to the next slide, please. So in terms of, I'm just going to summarise what we've talked through so far. So what we saw in the data was that demand was increasing and exceeding capacity. Locum activity had risen by 185%, and this comes at a huge cost to the practices within the PCN. There are significant health inequalities across the network, and couple all of that with this workforce crisis, we really felt that a radical redesign was required in order to increase access and increase equity to services in North Sedgemoor. The solutions include optimisation of current acute pathways, enhanced triage to make sure the right patients are getting the right appointment, integration of the same-day care hub with GPs working more like an ED consultant might, in a consulting fashion, but also factoring in them seeing 20% of the more complex patients. Optimisations of the ARRs roles with introduction of first contact practitioners for musculoskeletal conditions, a mental health hub and a women's health hub. Integration of AI technology for the management of skin lesions. And overall, probably the most important thing really is to try and enhance that collaborative working across the network to reduce health inequalities and improve access. So I'm going to stop there and hand over to Kyle for the last slide just to offer some reflections.
Yeah, sure. So we had a really fascinating time coming off the back of the presentation, and how did that make us feel? What did we reflect on it? And it didn't really tell us anything we didn't know, and yet it did at the same time. Lots of those things we were aware of, but we now have actual evidence that gives it to us directly, which we've never had before, and that was really challenging. It really challenged the teams that are in place in the practices, because they then had someone saying this from the outside based on evidence, not just what you feel or what you think is going on, and that was incredibly powerful. Some of the ideas that we had that were really big moments of opportunities was, how do we actually implement this in a way that's going to be sustainable, particularly around the money and the people? We've got 5 different businesses that are operating, and what we're talking about is working together in a different way. We also think that it's not just primary care. Same-day care is a system-led approach, and how do we allow money to flow and transfer to allow those things to be done? Because this is a part of the GMS contract, and therefore we're taking that out of a practice and putting it somewhere else. And how do we redeploy people? How do we redeploy money? And how does that affect you as a business owner, particularly? That's a significant challenge that we need to be facing into. And the teams were really challenged by that. And that's still where their concern lies, around the level of the detail, and the devil's in the detail, really. I think what was really helpful is that this idea, and I think someone mentioned it in the chat, and I'll try and touch on it, this idea of, well, how is that different than what we're currently doing? And the challenge from the data showed that we're literally doing whatever just comes in. We're not really prioritizing same-day care, and therefore we're not able to do the complex stuff back at base. And this model allows us to say we're going to be more effective at triaging same-day care. And therefore the 12-minute appointment or the 15-minute appointment that a GP has is to solve an actual same-day care problem, which should be solvable on the day to an extent. And therefore what's left back at your base is the increasing level of complexity which we're all facing into, because things have not been picked up and not been managed so well. And that was really, really helpful. So those are some of the reflections. And it helped to be able to say that, you know, not just what you feel in your bottom line, but knowing that we've increased our locum usage by almost 2 is mad. And it's not a sustainable model. And someone has mentioned again in the chat that, you know, one of the reasons why that's come, it is partly because of the money, but also it's because what we're offering in primary care isn't safe anymore. And locums are dictating what they feel is safe. And yes, they are creaming in the money for it as well, but they're dictating what they feel is safe and appropriate for them. So they're saying, I will see this many patients, I won't do home visits, or I will have my slots in the afternoon open and only I can book into them. And we have clinicians now who are asking and dictating what is safe to them. And therefore we have to look at that model and say, we need to look at changing that to make it safe for everyone. The challenge then is about how do we get the path moving forwards? How do we make this happen? And it has already been raised, and I mentioned it briefly, but the significant challenge of you're moving something that's part of GMS work into somewhere else, and you're optimizing it and you're making it more efficient. But how do you pay for that? How do you make that a sustainable model moving forward? And currently, the big challenges are, does the contract allow for those things to happen? Who pays for that, and how do you continue to pay for that? And part of the model that Clear have been able to deliver is, you know, there's a significant level of training and supervision that's required to have these people work in a way that makes them really effective. And they've been able to build that into the model, which is very, very helpful, because beforehand, we have to be honest, we don't have that in primary care. We don't have the headspace to train people. We don't have the headspace to supervise appropriately and properly. And we're forcing people to operate in levels and realms that they're not comfortable in, and this model allows us to do that. I suppose the challenge then is the future. We know what we need to do. We know that we've got these different types of hubs and centralizing those things, but can we make that a reality? And at the moment, there are still significant challenges within the practices around how are we going to do that? How do you share that risk? Because all of a sudden you'll be seeing other patients from other practices and those sorts of things come along. And we have a significant challenge about how do we implement this in a way that doesn't then destabilize what's back at home. And our first step on that was we looked at the NHS England request for setting up respiratory infection hubs to manage winter pressures, which happens every winter, funnily enough. And we've asked to have a punt at that. Somerset wasn't able to deliver it on the 2 places that they prioritised. Again, because of all the pressures that everyone's under. We said we'll have a go at that, because that is the start of same-day care hub, and we can look at how do we do this in a safe way and move it out. And we've been able to do a lot of work on that to get things in place. But like Eve had mentioned, it's exhausting. A lot of us don't have the headspace or the extra time, and we're working overtime and doing stuff at the weekends. And we do have a lot of the solutions, and most people do, but we just don't have space to do it. And therefore, this is where Clear are coming through with opportunities and ideas, and there's different people who can do that. And we need that support to have people to facilitate and allow us to deliver and build something that can be done. Yeah, so I think that's probably all I've got to say. I don't know if I've answered some of the questions or all the questions, or if there are more, please come on board, I suppose.
Thank you both. That was really, really fascinating, and thank you for being so realistic, I guess, Carl, and what you were saying. Should we just address first of all just some of the questions and issues that were raised in the chat? Susie, would you like to just talk a little bit more about your question with regards to the 12-minute modelling of consultations?
There has been an answer in the chat from Eve saying it's not a recommendation or an assumption. When it was in one of the star boxes at the bottom of the slide, it looks as though you were building into your future plan a 12-minute GP consultation. If you take out mental health and women's health and same-day stuff to your same-day care hub, what is going to be left behind are going to be complicated. And most GPs already do effectively 15-minute appointments by building in catch-up gaps. Some of the people who have 15-minute booked appointments still need to build in catch-up gaps in order to provide safe care and run to time. So I was just interested in what your modelling would look like if you actually modelled 20 or 30-minute GP appointments, which is what most GPs think we probably need for the complexity of what we're dealing with.
From how I understood it, sorry, it was proposed that it would be a 30-minute consultation to actually make a significant impact on complexity. I may have remembered that wrong. I'll pass back to Eve.
The data on that, so from the data that we have, we can look at the length of the consultations that are currently being provided, and the length of the consultations that were currently being provided was 12 minutes. So the data that you saw was looking at the impact in terms of saved consultation times. So we used the data that we had, which was 12 minutes, to say this is the number of consultations that could be saved with redirecting of the care elsewhere. So it's not a recommendation to have.
Yeah, it's the difference between looking back and looking forwards, and it wasn't entirely clear to me on the slide that that's what you were doing.
Yeah, yeah. So yeah, no, that was just based on the historic data.
So we've got lots of questions and things in the chat. Should we just very quickly just touch on the difficulty with obviously the pay with regards to locums and what GPs are currently taking home. I'm guessing, Carl, that's a question for you. It's difficult to handle, I guess, from your point of view.
Yeah, I think we need to be very honest and face into that it's significantly impacting the partners and the businesses, but also moving what we're doing will also have a significant impact on how that money works moving forward. And no matter which way you look at it, something's going to have to move. So do you redeploy people, your own people, to deliver something like this? Or do you allow money to be diverted because now work is being done that you were currently being paid for before? And then you've also got lots of challenges from within practices saying, but we're double paying for things because if someone goes to MIU, they're getting paid for it differently than we are, and we're not the only ones doing all of same day care. And this is where the contractual elements really butt up against this, and they aren't fit for purpose to allow us to deliver this in a way that then just makes it very, very clear. But we have to face into that as a system. We have to face into that as primary care. That needs to be looked at significantly. And the direction of travel is to look at how do you ensure something is sustainable, ongoing, and allowing money to be cycled in, but at the same time not completely destroy a business that has built its, the whole purpose of what we're doing in primary care is to look after patients. But we're now at a point where that's significantly affecting people's livelihoods. And it's how do we ensure that we don't destabilize that by building something else? And unfortunately, there will be this sort of awful curve where when we're doing something like that, we'll take people out or we'll have new people coming in that will take on some level of burden. And while that is scaled up in a safe way, it does risk that level of destabilization behind. But you have to sort of go through that pain threshold. And we're not really sure if, as practices and in primary care, we're ready to do that. But I think this has been the biggest reflection from the practices. They've never been at this level of stress and environment where they're forced to change. But when you're involved with serious amounts of money, it becomes a significant challenge of how do you do that without basically chopping your hand off. And I think, those things need to be faced into, and the challenges we have with those are not insurmountable, but they're big. And that's at the moment a big significant challenge that everybody is facing in primary care.
Thanks, Carl. There's quite a few questions on these. I'll just very quickly put for Eve from Melinda. She was asking, can you explain why the deprived patients had less access to appointments over the 5 years?
It's a really good question. I think that the deprivation was different at different practices, and those with the more deprived patients had more difficulty with workforce and recruitment and access. So I think it was in part that. It would be useful it would have been really good if we'd been able to kind of talk to patients in a bit more detail to gain some insights from them. But I think it was in part due to that difficulty recruiting in specific practices that had the lower decile patients within them.
Thanks, Eve. Aaron. Sorry, did you hear me?
Thanks. Yes, thanks. Thank you for the presentation as well. It's really helpful, really informative. What I really wanted to understand was you talk about telephone access, but how does the online access feed into your model?
Oh, so that's a good question as well. So yeah, there's also an online route into the central single point of access that we've factored in as well. So it would also take e-consults too.
So it does, or it would?
It does. Well, I'm saying would because it's not implemented yet, but it does factor that in.
Okay.
Yeah.
Thank you.
Lorna, you had a question.
Yes, thanks. Great presentation, actually. Really interesting to hear about it. Kyle, this question is probably more for you. As one of the aims was around tackling health inequality and access for people with high levels of deprivation, I'm presuming that means the hub was located in a geographical area that better serves that deprived population. And if it was, what have you done as a PCN to mitigate the complaints that the practices on the other side of the M5 are likely to get now patients are being diverted away from seeing their GP in their own practice and being asked to travel somewhere else to see someone else?
Yeah, so first things first, I think it needs to be said that the hub doesn't exist yet. We're at the stage of trying to build it. This is not unique to our PCN. This is a sort of similar thing that is covered across the whole of primary care networks. We've had this pushed, and I mean heavily pushed, from all 5 practices around our patients won't travel. They're never going to do this. Initially clear then, because of that, I mean, that was hefty feedback that they received. Their initial model was 2 hubs, one on each side of the M5 to try and make it fairer, I suppose. What we were able to get from some of the other data from our secondary care colleagues and what we were able to see is that if you're not getting your appointment, which all practices have that problem, they're not all achieving all their appointments. We're also noticing that people are driving past all these different places to go to MIU and to go to hospitals and A&Es, but not even just the closest one. They're literally driving everywhere to get their appointment. And when people need that access, they go. The other thing that we were really fortunate is with COVID, we had a central place that was where we're proposing to use the hub. So everyone actually knows where it is. It's got a car park. It's not the easiest access depending on which side of the M5 you're on. But we know this is a problem that we have to face into. We've spoken to the ICB and our council colleagues and said, look, we have a significant problem that there is literally no transport link from one side to the other. And if this is going to be a sustainable model and a safe model, there needs to be that transport link factored in, like some sort of shuttle bus run or whatever it may be. And they're seriously considering that because they recognize in our area, particularly, they've got this huge risk of destabilization. And so we've been able to start looking at that. And at the moment, the model, when it will start with the acute respiratory hub stuff, will say, if you're unable to travel, then we will still allow the urgent appointments to be managed by your practice. But we are also very aware that some of them can't do it on the same day. And therefore, they're just thinking if you can take that as an appointment you get today, people will try for it, and it becomes a needs must type model. But it is significant, and we need to face into it. But we are going to be on the deprived side of the M5 as such, or where it's more prevalent. It's on both sides, but it's more prevalent on one, and we're going to be much closer to that side to try and bring it up together, I suppose.
Thanks, Carl. Just going to we're going to a couple of other questions. There was one question about how does this model fit with continuity of care and what happens if a same-day issues require follow-up? How are these aspects dealt with within the PCN? So, do you model for that, Eve, as well?
I don't know who you want to answer. I'll give you a quick insight. Continuity of care is an interesting one because I think the definition of that differs amongst lots of different people. So what that means is interesting. Is it adherence to a care plan, a team? Is it the same person? And I suppose the other thing is it necessary for an acute problem? Continuity of care is obviously important for complex health needs for specific populations, but what we're recommending here is very much for the same day care thing. So you've got a lower respiratory tract infection, you've got a UTI. These people are just people that want to see someone quickly to get a solution. If the same day care problem would require follow-up, then they could go back into the GP system. So there would always be access back into that. And we've also created a system within the triage approach that flags patients that shouldn't go to the central hub, that should always be directed straight to their GP to ensure that they've got that continuity of care there for the more complex patients. But Carl was going to answer as well, so I'll let him talk.
Yeah, so literally that, and then from an element of if follow-ups required, part of our model is to use a sort of cloud-based version of we're all on EMIS in Somerset, but a cloud-based version of EMIS to allow us to make sure that seamless care is done. And because we've got our GPs wanting to work in this sort of consulting type fashion, that they can actually be part of the solution to facilitate how they handle the follow-up and the triaging of, you now need to get in for your review because actually you've been diagnosed with a COPD exacerbation, you got to be checked up. And we can look at methods of facilitating that to try and stop just a huge amount of burden being chucked back onto practices that have just then gone, I thought I just got rid of this. And it's the whole idea is if we've allowing GPs to work in that consulting fashion, they've got a little bit more time to consult remotely to handle some of that stuff and how they facilitate that back into practice to being a bit more slick. And that's what they're all quite excited about, going, I'll have time to actually do that rather than just task it to someone, which is quite exciting. So that's kind of how we're hoping to be able to manage that.
Thank you. Just going to take one more question from the chat. In mining your clinical data, were you able to successfully identify different urgent need types that are presenting and in what volume that comes from?
Yeah, so yeah, we could. So it's quite a task that is because of the read codes and the inconsistency of read codes. So there's from one practice alone, there are 15,000 different read codes associated with the consultations. So we went through them and we grouped them in order to get a kind of a picture really of what patients were presenting with and what proportion of patients could be managed in different ways. And that's kind of what led on to the ideas for the hubs, because musculoskeletal conditions, mental health conditions, skin lesions were a large proportion of the acute demand for those urgent same day appointments. So yes, we can, but it takes a lot of time and a lot of work, just because of the quality of data. I mean, one recommendation I think for primary care generally would be around how those read codes are coded to enable programs like this to be a bit easier going forwards. Does that answer your question, Ian?
Is Ian still on the line?
Yes, it did. I've got 1,000 follow-up questions, so I might get in touch offline if that's all right. Fascinating that you've done it though. It sounds amazing work.
Thanks for that question. So I just had one question I wanted to put to you, Carl, just as we finish up, is there consensus now on, have you got consensus with the practice on which particular recommendations you'd like to take forward and what will be your next steps?
That's very fascinating. There is now, because of all this data and what it shows, I would say there's actually there's much more fear involved now. That's more real, because beforehand it's a level of uncertainty and unknown, and now that's actually been crystallized. So there is fear about how are we going to manage doing something like this when it does affect how my future looks as a person who needs to make sure I can pay my mortgage, but also keep my sanity going from a day-to-day basis of, oh my days, how am I going to do what's in front of me? So that's been fascinating watching how that has played out. There is probably for the first time in our PCN, a consensus to say we totally agree. We actually have to do something drastically different, and that seems quite maybe small. Going, well, obviously you need to do something different, but I think when people are in that sort of stress and that environment, and primary care is well, every sort of profession sort of in these sorts of situations at the moment, aren't they? But to have that realization come forward has been quite something. There is huge concerns around who basically will do this and how are we going to get these people in, and you're going to steal all my staff and they're going to go jump to the ARRs rules, but they all recognize that they have the potential, if they do it together, to do it together. And there is still a lot of trust to be built around this, because people are still wary about this idea of your continuity of care is completely different to mine. My continuity is I know all my patients and they're just my patients, rather than I've got a continuity of care plan that they are, their condition and their problems are all known, and that's where that is. So they basically said, we want you to try and set up the ARI hub. Let's try and do that in a slow and a safe way, even though now the numbers are much lower. Although at the minute the COVID numbers are going back up again, and respiratory infection seems to have a little bit of a spike at the moment. They're keen to see that work so that they know that they can send people here, and they want to see what the outcome of that looks like. But at the same time, there's almost a desperation going, if I can shift that same day work off my desk today, please do it. But then the big thing is, if you're a partner, how does that affect your take home income? And from a contractual point of view, how do you know that that's been covered and covered well? So there's a willingness, but at the same time, there's a huge fear around it. So it's overall, it's really exciting. That's kind of where we're at. And Claire have been really kind and sort of come forward with an implementation sort of plan and an offer of, we want to be able to help you do this. We could do a light touch where you're mostly involved and we sort of support you with it. We can do a heavier touch where we basically give you that support and help deliver it. And those things are being pushed forward to us, the ICB, NHS England, around what's the best mechanism forward. I think he pointed it out very clearly. We have a lot of the solutions. We just don't have the capacity to deliver them. And that's where a lot of us get frustrated in what we're doing on a day-to-day basis, because we know it needs to change and we don't have the impetus and the time to make it happen. And yet we all literally know it needs to. So it's an exciting time.
Many thanks, Carl. Eve, you just wanted to say something?
It was just a final reflection, really. So I've just as well partly say thank you to Kyle and everyone at the PCN, because it's been a really nice project to work on, and it's been a really good, collaborative approach to what we've done. And I suppose the other thing that's really stood out to me from this project is just how stressed everyone in primary care is, and how just providing that a bit of space to think and providing the data can really just pull everyone together. And that's what's been really nice to see everyone across the network kind of pulling together to try and make change for the benefit of the patients. And I think that I just wanted to say thank you really to Carl and his colleagues for helping us to achieve that. And I really hope that this gets implemented and has the impacts that we're projecting.
Thanks, Eve. Just very conscious of time. So many thanks to you both for speaking today, and to everyone who attended today. If you haven't already, please sign up for further Clear Week sessions. All the details are on the Clear Week website, and if you can share with colleagues. Our next session is this afternoon at 1:30, when we'll be focusing on the expansion of a dedicated high-intensity user service in Warrington, and we're joined by 2 high-intensity user leads as well. And also after that, we have an international session when our Clear National Lead, John Jeeves, will be talking to a colleague from Main Health on the challenges that we face here and across the pond, and comparing them. So thanks very much. If you have any questions, please contact the Clear team. Have a lovely day.